Okay, good evening, everybody, and welcome to the Your Freedom Hub Free Market Cash Patient Webinar Series. I'm your host, Jeff Cantor, along with Charles Froman, and want to encourage you to subscribe to all of these as they come out. So this is the web link you'll want to go to and just register to be able to get a notification for all of them. We do also archive these on a variety of platforms, Brighteon here being one of them. I'll show you that momentarily. Also coming out on YouTube, and we're currently on BitChute as well. So let me give you a quick diversion here for a moment, and then we'll start to go right into what we're doing here tonight. Again, we're sponsored by Your Freedom Hub, especially when it comes for this evening to the idea of having this health disruptive program. And we are archiving, as I said, there's some really spectacular ones you'll want to see here and share. As I said, they're in a variety of play areas, so wherever you like to go, that's where you'll find them. And then in terms of where we are today, hold on a moment here. All right, Charles, why don't you do the honors here and let us know what's going on tonight?
Gladly, Jeff, and welcome Professor Grinols.
Thank you.
And I think I met you somehow through the Governor Gary Johnson presidential campaign, 5 or so years ago, when for the nonprofit indirectly tied to that campaign, Our America Initiative, we were coalescing with groups to push all the big issues in the Liberty area, and we formed these advisory councils, having telecom people, judicial people, econ people, and Earl was recommended to me somehow, I don't remember Earl, for I think the Healthcare Advisory Council, or was it the Economic Council? I don't remember, maybe you will.
I think it was healthcare.
Yeah, so over the years, as I got involved with Jeff in the healthcare disruptive space, we would go back to Earl, and we found out that not only was he an econ professor at Baylor, but that he also was on the committee helping his giant university, decide how to cover their employees with healthcare expenses. And as Jeff and I have gotten deeper into the innovative space of healthcare, we've realized what a roadblock and logjam universities and other big groups really are for innovation. And I hope we can get into Earl's personal experience, not with any naming names, Earl, but just sort of the general dynamic, the difficulty it is for an innovator in a big bureaucracy to push innovation. It's got to make you think you're slapping your head against the wall. Reading up on Earl, I saw that he made his name over the past few years kind of slamming the economics of gambling. And maybe we can divert into that later on in the call. But the cool thing was he was a senior economist for Reagan back in the 80s on the Council of Economic Advisors. And, we definitely want to know how you got that gig, because that's very high level. I'm thinking Martin Anderson and all kinds of names from that decade, very high level all-star staff of thinkers that decade. For tonight, we're going to talk about his book, Healthcare for Us All, Getting More for Our Investment. So that's our introduction, Jeff.
Fantastic.
Does everybody have that?
That's excellent.
Okay, so I've titled this Fixing What's Sick in U.S. Healthcare. It is my attempt to undo John Goodman's rule about healthcare, which is that everybody's IQ drops 15 points when they discuss healthcare. So since we don't want that to happen, I've tried to put this together to counteract it. At any rate, the things I want to say I've divided into 3 parts. The first has to do with a little bit about how things are now. Then I'd like to talk about what an ideal or perfect system looks like. And then finally apply some of the things we know that would move us toward that perfect system. And after doing that, take questions if there are any. So I'm going to begin with what I call a tale of 2 healthcare systems. And this is a true story, but these are 2 countries. And in these countries, 2 individuals had the identical diagnosis. This was lower back pain that with the same prescription, which it was bad enough to need surgery. In country one, the individual was seen within 2 weeks when he tried to get seen. In country two, same identical prescription, same diagnosis, everything as close as you could have to be a match. This individual had to wait 9 months before anybody would see him. The recommendation in country one was for outpatient surgery, microsurgery, which was done. In country two, he also asked for the microsurgery, but in country two, he was told, no, we don't do that here. You don't have that as an option. In country one, the microsurgery was done. It took 1 week to recover. In the other country, the person was put into the hospitals for old-fashioned large incision surgery. It took 6 days in the hospital. And for that individual, it took 6 weeks of recovery, in which time he was off the job. Meanwhile, in country one, the individual is back to work in a week. So that is a major difference in how the identical diagnosis, same prescription was treated. Country one is the United States, and country two is Canada and the Canadian healthcare system. So people who think the Canadian system is the goal or ideal that we should strive to should be thinking about this example. The company is Gorton Seafoods, and this was a information I got directly from the president of Gorton Seafoods. Gorton Seafoods has its U.S. branch in Massachusetts, has its Canadian branch called Blue Water Seafoods in Quebec. And what the president told me is that their Canadian employees really very much wanted to get onto the American healthcare system and did not particularly like the Canadian system. Now, my takeaway from this story is that Medicare for all is really a form of animal husbandry. It's not volitional human healthcare. And what I mean by that is when the rancher decides what healthcare his herd of animals is going to get, he decides what's available, he decides what's cost effective, and he decides which animals are treated and which aren't. So I would say that the Canadian system in this example is closer to the animal husbandry. So here's some numbers about US healthcare today, and there is a message in this. We know from various studies that roughly 21% of spending in healthcare in the United States today is unnecessary. We also know that about 54% of US healthcare is shoppable, but it's not being shopped. And because it's not being shopped, we're losing out on what the proper shopping would do. So it's estimated, and by the way, I checked this on Baylor University data, and it came in at exactly this level as well. But of the 54% of shoppable services, you could save about 45% of those expenditures, which implies about 25% net savings on that portion of healthcare. In the United States today, about 31% of healthcare is hospital care. And because hospital care is not competitively offered in the United States, there's very little competition in hospital care, we're losing out on 5 to 10% of costs that could be wrung out of that portion of healthcare if there were competition. Now, my own personal research found a number of 8% could be reduced if there were more competition in healthcare. So taking all these numbers and putting them together implies that in the United States today, we're spending somewhere between 2 to 2.5 times what we ought to be spending on healthcare. And that's an enormous cost. And the thing I should point out is if you compound the problem by telling a large portion of the population that they should expect not to have to pay anything for healthcare, let's say half the population, you have to put all those 2 to 2.5 times costs on the other half that is paying for the healthcare. So in a case like that, you could have a situation where those who are actually paying for healthcare might be paying as much as 5 times what they ought to be paying in a properly run system. That is the magnitude of the potential that exists in the country today, especially if we went to a Medicare for all type system. So Obamacare has come along since 2010, and as people have found out, that's made things much worse, especially for the middle class, even though it can still be profitable for the insurance industry. We know nationwide, on average, premiums have doubled. Far from reducing the average middle class person's costs of healthcare by $2,500, which President Obama promised, premiums have doubled. We know deductibles have tripled. Networks have narrowed. Guaranteed issue, which was a major reason for Obamacare, is still unsolved. And we know that insurers in the United States have an incentive to attract healthy clients and avoid the sick. So in general, people with healthcare problems are being mistreated. Now, Bob Lazuski, who was quoted in American Healthcare Choices last November, said that Obamacare should be understood as kind of a zombie care. It's going to stumble along just like a zombie. It's like The Walking Dead, still selling health insurance policies, but it has no chance in its present form of ever offering affordable care and attractive health insurance. So the solution is not to fix Obamacare or create a system where we provide Medicare for all. So what would an ideal system look like? And it's really very simple to describe. Imagine every baby boy born in 1997, for example, being placed into a common pool. Every baby girl born in 1997 would be placed into a pool for girls, and do this every year that you have a pool created. Once a pool is created, every member of that pool pays premiums into the pool annually, insurance premiums, the same identical amount. They all have the same health insurance plan. And the pool pays the claims for the members from premiums of the pool for the year in question. As the pool ages, the premiums would rise, but they would rise the same for all members of the pool. Everyone would stay continuously insured, so there's nobody trying to free ride on dropping insurance and then coming back when they need it. And so that's it. That's the advantage of the way a simple insurance system would work in an ideal world. So what is the problem? Why don't we have that ideal world? And the issue is the non-compliers. And I phrase it this way. For various reasons, some people don't want to pay for health care. They don't want to pay for health insurance. But if they have a large claim, they want to be covered nevertheless. And that is the essential problem with the country today. We have about 10% of the population not covered with insurance, and they're simply not complying with the system. Now, the symptom that I just described, the non-compliers, is what I call an example of magical thinking. Imagine somebody saying, I don't want to pay for food, I don't want to buy insurance for my car, but if I have a problem, I want the food given to me for free, or I want my car damaged repaired for nothing. But it's broader than just this issue here. And so I want to highlight, in talking about how we get from where we are to the ideal system, to expand on this magical thinking in three distinct ways. And these are three ways in which Americans want or expect health insurance and health care to do things that markets just simply don't do. There's a way to accomplish these things, but you have to get around this quote, magical thinking. So first of all, Americans expect somehow that we can have low prices, falsely believing that that can happen in the absence of competition. The presence of Medicare in the US healthcare system since 1965 is largely the single cause for the lack of competition we now face, and that is largely the result, or the cause of the resulting high prices that we face. Number two, individuals want insurance companies to sell policies at standard premiums to individuals who the companies know in advance will have enormously above standard claims, somehow naively thinking that companies should be able or willing to do this. And thirdly, Americans want citizens having the expectation of receiving free insurance and free care, nevertheless to act fairly and responsibly in the use of those insurances and care without the discipline and accountability that markets provide, somehow imagining that this can be done. So none of these three things is possible without making some adjustments. And so now I'd like to go to some suggestions based on standard economics that will solve all three problems and will cause our system to do what the system needs to do, plus some of these things which systems are not designed to do. So let me just talk about that. So this is the book that I wrote with my co-author James Henderson. It was published in 2009, Cambridge University Press, which is very good economics press. And the purpose of this book was to put it into the hands of congressmen and senators with the idea that we might be able to favorably influence the legislation, the Affordable Care Act, the Patient Protection and Affordable Care Act, which was being considered. I did get to Washington. I did talk to a number of congressmen and senators. Copies of the book were distributed and so on, but as people may guess, I don't feel we were very successful in our overall mission. But it does talk about good economics and how it should work with healthcare and with insurance for healthcare. It talked a good bit about incentivizing everybody to want to buy health insurance in the least damaging, most sensible way. And it also put in a feature, which I can talk about if people have interest, that would give the federal government budget control and advance certainty about how much money would be spent on their healthcare expenditures. So we have 6 components, and I've created an acronym with these components. So the first letter in the acronym is T for transparency, which relates to prices. And let me stop for just a second and preface this particular part. If there were only one thing, a single thing, that the federal government did in healthcare, this would be my recommendation to be the most helpful single thing if it were the sole legislation that could be passed. And it goes back to just after World War II, when the Allied nations had just defeated Nazi Germany and the Japanese, but the world trading system was in chaos, and the General Agreement on Tariffs and Trade was set up in order to restore competitive markets in international trade, to restore the benefits and advantages of those markets to the countries of the world. The General Agreement on Tariffs and Trade has as its very first clause the most favored nation clause. And by taking that most favored nation clause and adjusting it just a little bit to apply to healthcare, we can apply the benefits of markets and trade to the healthcare and health insurance markets. So here's how a most favored customer pricing clause would read, and this would be something that could be passed by federal legislation, would take literally half a page of a bill to write, and here's how it would read. And it follows the General Agreement on Tariffs and Trade legislation. With respect to prices and charges in connection with healthcare products or services, with respect to the method of levying any such prices and charges, and with respect to all rules and formalities in connection with supplying healthcare products or services, any advantage, favor, privilege, immunity granted by any supplier of healthcare products or services to any buyer of healthcare products or services shall be accorded immediately and unconditionally to the like product or service destined for any other buyer. Now that is almost word for word the most favored nation clause of the General Agreement on Tariffs and Trade, except we're applying it to healthcare. What it would do is allow, or require, I should say, every healthcare provider to pick whatever price they wanted, but they would have to pick a single price and charge that single price to anybody who bought their product. If they wanted to offer the product for free as a charity service, you could allow them to do that. But anybody else buying the product would be charged a single common price. And economists understand why this would restore competition into the healthcare sector. So this would be the first thing we would do, and it's a very simple piece of legislation. The fix number 2 would be reinsurance, and I'll explain reinsurance this way. If you wish to have an insurance company guarantee issue of its product to somebody who shows up to buy insurance, even to people who are high-risk individuals, or even people who have perhaps become uninsurable, then you would need to have some kind of insurance for the insurance company to handle the risk that they would have a huge portion of uninsurable people show up at their window wanting health insurance. There are a number of different ways to do this. So the details are not so important to go into right now. But reinsurance, or insurance for insurance companies against a bad mix of clients, would support guaranteed issue, which is what Americans seem to think they want, and it would support guaranteed renewability. In other words, no matter how sick you became with health insurance, you would be guaranteed that you could continue to renew your coverage at standard premiums, regardless what permanent medical condition you may have acquired. Reinsurance could be set up on a statewide basis. It could be done nationally through different mechanisms. As I said, the details are not difficult to go into, but there are various formats that could be done that would support reinsurance. So that would be the second thing that would be needed to get what Americans want from their healthcare system. Okay, I got 4 more fixes. Fix number 3, accountability. And this is something I have not heard other people talking much about, but it has to do with the careful use of healthcare. And I've framed this in terms of EMTALA reform. EMTALA stands for the Emergency Medical Treatment and Active Labor Act. That's a federal government piece of legislation which says that if you show up at an emergency room, whether you can pay or not, you have to be treated. Same thing if you show up and you're actively in labor for delivery, you have to be treated. But the way the legislation reads now is even if you're treated, there's no obligation that you have to pay for anything. And many people rely on that and take advantage of it and leave emergency rooms paying nothing. Now, here's what needs to be changed to reform the EMTALA legislation. Number 1, and let me just make a little background here. If you pay for something now and you receive it now, that's what we call a spot transaction. If you pay for something now, but you receive it later, that's called a forward transaction. There's even agreeing now, paying in the future and receiving in the future. That's called a futures transaction. But we know that if you receive something now and you don't pay now, you've just incurred a debt. We need to recognize these medical debts that the EMTALA legislation is currently not recognizing, record them, and make provision for paying those debts off into the future. If somebody cannot pay for their health care today, perhaps they can pay in the future, and they should have some method that they are being tracked, they're being collected from in the future, and these medical debts covered. Now, in addition, we can talk about a collection mechanism being established, including a government supervised fund for those who would want to volunteer to help other people pay these kinds of medical debts which are incurred. So anybody who thinks that Medicare for all is their plan for the country, anybody who thinks that the federal government should be helping give people free care, those individuals can voluntarily pay into a government supervised fund and help pay off other people's medical debts. I should also point out that a government supervised fund means collecting medical debts recycles the help to help other people. And that's an important change. Okay, finally, insurance can be redesigned to improve it. There should be no utilization gatekeeping. It's not the job of the insurance company to tell you what is covered, what's not covered. If it's a medical procedure If it's a necessary procedure, then the insurance should cover it, and the insurance company should not be acting as a gateway to prevent you from getting care. In addition, premium should be actuarially fairly set by age and sex. This is currently prevented by federal law. Again, age discrimination and sex discrimination prevent actuarially fair rating, and that ought to be changed. The basic rules of premium setting are very simple. If a person enters a healthcare pool, they should expect to pay a premium equal to the expected cost that they impose on the pool. And if somebody can't pay, they should be either left out of the pool, or in the case of these proposals, someone else should be making a contribution on their behalf so that they join the pool. And when premiums are changed for a pool, everybody in the pool pays the raised or lowered premium at the same time at the same rate. Finally, charity should be based on need and not in general. The current entitlement programs in the United States fail to follow a basic economic dictum. It is a rule of policy intervention that the need of a system should be targeted in the least extensive way possible to meet the objective. So if we have a small group of people who currently don't pay for health care or health insurance, maybe because they're needy, then the aid should be targeted just to that need-based group. You don't create a Medicare for all system because 4 or 5% of the population are unable to pay for their health insurance and their health care. You create a system where the charity aid goes only to those people who need it. And you can show from the economics that is a less costly, less damaging way to do your policy. So everyone will have insurance. Everyone has access in these plans, but we do it in a targeted way. The government supervised funds endorse and encourage people giving voluntarily for premium support and for debt reduction. That's a change to our current arrangements. And lastly, I'm sorry, so those are the 5 fixes. The acronym I was able to come up with spells the word TRAIN: transparency, reinsurance, accountability, insurance reform, and need-based charity. And I'm going to end now with just a few little comments and take questions. But those things are all that would be needed, I believe, to fix the healthcare system that we have in the country. First of all, I want to explain to people in the easiest way I can why in this country government is the cause of the healthcare problems that we face. In this slide, what you have here is a chart from a research paper. Across the axis down here are age groups. So these are individuals 0 to 14, 15 to 19. This is the age group of people 50 to 64. And here's people 80 years and older. So these are 10 countries' expenditures on healthcare, and they are zeroed in on the 50 to 64-year-old age group, so that they are all been set to 1 at that level. Now, of these 10 countries, you've got Canada, the United States, Norway, Japan, Germany, a bunch of countries, Sweden. In the United States, our healthcare spending just absolutely skyrockets once somebody reaches age 65, compared to Canada and all these other countries that are being plotted. So you might ask, what is going on to cause American healthcare to look so wildly different from other countries once age 65 is reached? And I don't think anybody finds this too much of a mystery. It has to do with Medicare. Now let me go to one more slide and then I'm finished. This chart shows income earned in the country, and this is the most recent year available. I think it's 2016 data, which I put together, and it in the bars shows the total amount of money in the hands of individuals earning in the brackets that are shown across the bottom. So for example, these are individuals earning $100,000 to $200,000 a year. Any such person in total is in this bar and earns this much money. over here, you've got people earning $500,000 to $1 million, and these people are earning $1 million and up. So you see all the bars. The red on these bars shows the taxes that each group is paying toward the federal income tax system in a given calendar year. The other thing to know about this chart is that income taxes are roughly half of the taxes collected in the United States today. So if you mentally imagine adding up all these red bars, you'd have a bar, about this high on this, and that would be around half of all the taxes paid in the United States today. Okay, now for the kicker on this particular chart. Elizabeth Warren proposed a Medicare for All program. She proposed a program that was recommended or required $52 trillion to be paid for it over a 10-year period, or in other words, $5.2 trillion per year. That is this bar's amount of money, her program, relative to the actual taxes being paid by all individuals in this country. So look at the size of this bar relative to these red bars. And even if you double all the red bars to get to all the taxes of the United States, you can begin to see why economists say that her plan is just, it's wildly unrealistic. And her plan is also optimistic on the tax side. The Penn-Wharton budget model says she wouldn't get the taxes at the level she claims to get them. So even as hopeful as she is, it's worse than she thinks. So I will stop there. And that's, I think that pretty much says everything that needs to be said. If there are questions, I'll be happy to take them.
We'll be definitely wanting to ask some questions against that, because you're right about that. It's one interesting observation in all the different shenanigans that have been taking place in healthcare through all these years and so on, that why of all the things in the world do people suddenly feel entitled to, I can go to the emergency room and not pay. No one feels that they're not going to get somehow having to do something for anything in America, except seemingly for when it comes to healthcare. How did that phenomenon occur?
Yeah, and that is the key phenomenon. Healthcare is what economists call a rival good. It's a private good, meaning healthcare that's one person gets benefits the person who gets the healthcare. If your appendix is removed, that benefits you. It doesn't benefit anybody else if your appendix is removed. And those kind of goods, we know, can prove are best produced and distributed in competitive private markets, just like food or anything else. I think the reason that healthcare is thought to be different, which it is not, is because of the creation of Medicare and then Medicaid since 1965. So people have got in their mind that if they can just get to age 65, from then on, they shouldn't have to pay for any medical care. And of course, that makes no sense whatever.
It's going to cost us all more collectively. Paul, I see you had your hand up.
Yeah, I just want to say great presentation. Learned a lot. I think that it's kind of an organic solution that's innovative and can complement pretty much any system. My question would be, if you are contributing to this kind of goodwill fund of sorts, is that tax deductible in your plan?
Okay, it could or could not be. That's a function of how the rest of the tax code is written. But and I had, to be honest with you, I had not thought about it. But I think if people wanted to make it tax deductible, I wouldn't have any problems with continuing a tax deductibility for giving money that aids somebody else in paying their healthcare bills. The reason is, under our current system, we have decided that healthcare expenditures should be tax sheltered. So if we're going to do that, we would probably make these tax sheltered as well.
Okay, very good. Thank you.
Charles, I see you got your hand up in the interim.
Thanks, Jeff. And I echo Professor Grinols, the comments of Mark and Leah. We're saying similar things, but your presentation was incredible. I can see why President Reagan wanted you on his economic advisors staff. A few points, just jotting down. We'll go through them, and I'm sure the others will have things to add. The transparency that you somewhat imply needs to be forced. I think Trump is trying to do that. I think those of us in the liberty movement are always loath to force anything, and maybe instead just erect a better model concomitant with the cartel that does reward good actors who disclose prices, and those companies that empower patients as cash shoppers and help them find those prices. Although, I guess you got to hand it to Trump that just the effort itself is, I think, embarrassing some holdouts to disclose their prices, even if they are kind of distorted in the hospital area. I'll stop there on transparency. I have other questions. We can move to other topics. Transparency.
Yeah, and if I could
comment on that.
If I could comment on it, you and I probably agree, and I've had discussions with my co-author Jim Henderson about this, because in principle, with enough time, you could get the benefits of transparency without forcing it. And you're right. The legislation, the most favored customer pricing legislation that I proposed earlier in the talk, is a forced way to get there very quickly. You probably would eventually get there merely by forcing people to post their prices in an easily usable way. I would be in favor of allowing the federal government to create a website and to require people to send their prices into the website, that the website would be searchable by location, by procedure type, by all kinds of things. And just by virtue of people being required to post their prices, you probably would eventually get to the kind of, you get to the same point. Although Abraham Lincoln is the one who said you can fool some of the people all of the time, all of the people some of the time, but you can't fool all of the people all of the time. I do think in some environments, maybe forcing to speed up the process, forcing the transparency and the commonality in prices might be warranted. But I think by and large, I tend to be more on the libertarian side myself.
Kishore?
Yeah, so my question is about the same issue about MFN principle of pricing. We are living in a situation where we have a bilateral monopoly. It's pervasive, especially in the hospital sector. And it seems rational for hospitals to oppose transparency rules that the Trump administration has brought in, unless the bilateral monopoly is itself unwound, and which is difficult as long as Medicare continues to underprice.
Well, and yeah, one of the things that hospitals are in there are a lot of things that put hospitals in a bind, and you're right. One thing I didn't emphasize in reporting the proposals that I made is that you can't just fix one thing and leave all the other things unfixed. Some things need to be done simultaneously. So for example, the transparency with the reinsurance mechanism and the accountability feature needs to be all three fixed together. It's like three legs on a stool. If the stool is going to stand, you got to have all three done at the same time. And just as you would, if you're going to force hospitals to charge a common price, then they need to be able to charge that price. I mean, they can't be faced with a government monopoly in Medicare. So I'm, in a sense, recommending getting rid of Medicare entirely, going to a competitive market in insurance, but just making sure that the small minority of people who need some help in getting the insurance and the care get that help. The debt, I've been a little vague about how there's some people who would pay off their debt in the future, but of course some people are going to die never having paid it off at all. And so there would be a certain residual amount of money that we're going to have to deal with somehow in a federal arrangement. And I wasn't very specific about that. But yes, I agree with you. You can't leave Medicare in place as a monopoly and then tell hospitals they got to be competitive.
Charles, I see your hand again.
Sure. And, Jeff, if you can sneak in a plug for WOW, where we are facilitating cash disclosed prices and shopping around that, feel free. To comment on tax deductions for charity. In our earlier weekly Liberty webinar, our guest economist Murray Sabrin alluded to Peter Drucker, the famous business advisor that everyone should know, who proposed a couple of decades ago complete tax deductibility for nonprofit donations as a replacement for welfare. So I think there is some good evidence that that's the tax way to go to facilitate that charitable part of Professor Grinols' plan. And Alita X Charity Health Center in New Jersey was mentioned, and we certainly had her as a host a month ago, as well as Leah Houston and her blockchain autonomy for doctors idea, and Mark Wilcoxon. Question, being long-winded here. Let's get into your political experience indirectly as a Baylor Health Committee person trying to upgrade your university system. Here you are with a book, a background as an economist with Reagan, a major disruptive mind. What kind of roadblocks have you faced trying to implement some of these ideas at Baylor?
So, yes, I'm currently still on the Baylor University Health Insurance Committee. Baylor University is self-insured. The entire plan, if you take every dollar paid out in healthcare in one form or another in a given year, you just round it, it's roughly $40 million we're talking about. And based on, we have an old-fashioned Blue Cross Blue Shield plan. In fact, Baylor University in the Blue Cross Blue Shield system is client number one. Baylor University helped create Blue Cross Blue Shield way back in the 1920s. I estimate my own analysis of our claims that Baylor is paying as a system probably $5 to $12 million too much each year relative to what should be possible with comparable coverage, comparable system. Yet, to convince committee members, other members of the committee, to take any bold action, bring in outside vendors, other people who might replace for us Blue Cross Blue Shield, and maybe go to a high deductible plan exclusively, those kind of things. I have found that task has been nearly impossible. The bureaucrat mind, in my experience, has been to make sure that nothing ever changes. And this kind of, to make those kind of savings is going to require some major change. For example, shoppability. In our plan, it's impossible to do any shopping. Even if you, let's say you need an image, you might be able to go to any number of 5 or 6 places that could do the imaging, but to just find out what is their price, what is the cost to you, how much would you save the plan, it's a virtual impossibility. And so I have to say I've been disappointed, I've been unsuccessful in getting our committee to take action to do pretty much anything. And in fact, I think I'm fair in saying that some of the members of the committee view their mission is to make sure that nothing changes. So yeah, it's a sad situation. Many people dislike change. Many people fear change. Many people don't understand change, and therefore they oppose change.
And oftentimes, I shouldn't say often, typically what I've ever seen, change is the best thing that could possibly happen.
Well, right, and in our case, I have been able to prove using our own data. I have all the claims that Baylor has paid on anybody over a 5-year period, including, for example, my own hip replacement, which was done in 2015. And I can use that as a perfect example. Just by default, I ended up using very good doctor, very good hospital up in the Fort Worth area. The claim that they put to the Baylor system for my hip replacement was, the basic claim was $60,000. Now, for the people who are viewing this, you can get a hip replacement many places in this country for about $15,000. The Blue Cross Blue Shield price for all of that chop that down to about 42,000. My actual surgeon was paid for a 37-minute operation, $2,400. And I was in the hospital from Wednesday morning to Friday morning and then left. So for all that I got, a surgeon being paid $2,400 Wednesday to Friday morning in the hospital, and that's it. I paid $42,000. It easily would have been possible to get the same quality hip replacement had I had any incentive to do so or any ability to do so for about maybe $15,000 to $20,000. I could have saved the Baylor system the difference, that $15,000, $17,000. Had I saved Baylor, let's say $17,000, what would have been the benefit to me? Nothing. I wouldn't have saved myself anything. And even though I could have been capable of doing some shopping and save the system that $17,000. This is the kind of waste that is going on in our healthcare system today. And if I can just go back to what I said at the very beginning, if you have a badly designed national healthcare system, you can end up paying 2.5 times what you ought to for good healthcare. And for those people who are actually paying for the other half of the population who expects to get free care, it could be a number that's 5 times as much. There's just no reason for it. There's no need for it. We know we can do it much better. And, those are the kind of numbers that we're talking about.
I have a question.
Go ahead, Jeff.
Yeah. If you were going to put together an advisory board of folks that would have influence in this space so that you could be better heard and hopefully acted on these sort of fiduciary-like issues that we have, who would you tend to who would you try to get on your team?
Well, if I could just, pick anybody, there are a number of names that I could think of, but John Goodman is one name that comes immediately to mind. He's the director of his own institute, the Goodman Institute. I think he's one of the best thinkers in healthcare. And I think the Galen Institute, Grace Marie Turner, I think has got a lot of good, but those are the kind of people that I would put onto the team. And of course, it requires that President Trump have the House and the Senate and the ability to pass legislation. As long as the government is split between the two political parties, nothing's going to happen.
Kisho?
Thank you.
I have a question about the role of something equivalent to futures and options as a way of insuring people against spikes in medical expenditure. So you could have, for example, a major injury and your insurance doesn't provide for all those expenses, or you have cancer and expenditures multiply very quickly. Is there a way to, I believe there was an attempt to introduce options so that you could buy insurance at a fixed price when your expenditures spike and manage the risk that way. I believe there was an attempt by Universal Healthcare to do that, but got nixed by Obamacare.
Okay, but I guess I'm not understanding how does that differ from insurance? I mean, that's the whole point of when I think of insurance is a basic major medical plan. You have a deductible, a co-insurance rate, and an out-of-pocket limit. With virtually anything that's a medical code covered, we're not going to cover elective surgery, hair transplants and that kind of thing. Right. But essentially anything that's a bona fide medical service would be covered by the insurance. And so I guess I'm not understanding the question from the perspective of how.
Well, there are two issues to that. One is that there are limits to how much insurance will cover in terms of max amounts, or you let's say if you're a young person and you want to have a bare minimum insurance, or you even elect to remain uninsured, for you, like it might be beneficial to buy cheap insurance, which has limited coverage, but you provide for something unexpected with an option.
I guess I don't have the expertise to answer that question because I've not thought about options and so on. I do believe that, I mean, there are two types of cost smoothing. One is in a given year, the random, need for health insurance, healthcare. But there are also other ways to smooth healthcare expenditures over your lifetime. But I mean, a 22-year-old healthy male is going to have premiums for a major medical plan, almost nothing. I don't know, $50, $60 a month would cover that individual. I didn't talk in the talk about the fact that you would need rules for getting people back into good standing. And in an ideal system, everybody is always continuously covered with insurance. You can't say, well, I'm healthy now, I'm going to not carry any insurance. But if I have a major problem, then I get to buy insurance at a guaranteed issue rate. But in order to induce people to stay covered and to have the coverage they're supposed to have, there'd have to be some mechanisms for restoring people to good standing on continuous coverage and so on. And as for smoothing somebody's insurance premiums year by year over their lifetime, I think a private market should be able to do that quite easily. I mean, that's just a matter of saving or not saving at different ages. You pay a little too much when you're young so that you can pay a little less than you should when you're older, that kind of thing.
Very good. Nice response. I wish we had some time for some additional questions, but sadly we've reached the end of our time frame here. Again, as a reminder, this is recorded. It will be released. This is the channel here as a reminder of one of the locations we've got. These are an awful lot of really excellent ones over time. And we are going to, like I said, have this available, sponsored by your Freedom Hub. So to find out about some of this stuff and a lot of these other innovations, this is where you're going to want to go.